Okay, good morning, everyone. The appointed hour is here, so why don't we go ahead and get started. I want to welcome all of you here in the conference room and those who are watching live to this program we have this morning. My name is Jim Capretta. I'm a resident fellow here at the American Enterprise Institute. And along with my colleague Joe Antos, I want to thank the speakers who will participate in the program, who have agreed to come this morning and share their thoughts, with special thanks to Congressman Bruce Westerman for agreeing to come and share his ideas with us. I will turn over the podium here in just a minute to my friend Avik Roy, who will introduce the congressman. But I want to take a moment, because that's what we do here at AEI, to of course give my thoughts first, about what we're doing here this morning and why. It's been almost 10 years since the Affordable Care Act was enacted. Over the past decade, the two parties have engaged in a near continuous debate, and that's putting it politely, over the merits of the law. The GOP tried, after President Trump assumed office, to repeal and replace the ACA, but of course failed. As we head into 2020, and the election that will take place just over a year from now, both parties are having to recalibrate their healthcare agendas in light of what's occurred over the last decade and the debate that took place, as well as on-the-ground realities about what's actually happening with insurance enrollment, coverage, costs, and other factors that are affecting Americans and their use of services. The ACA remains in effect. The law is there and it's working, and in some ways as intended, but it's clear it wasn't a panacea. There's still a lot of upset about the healthcare system in many different dimensions, insurance enrollment as well as costs and the pressures associated with it. The tendency of both parties is to gravitate toward ideas that fit comfortably within a fixed ideological point of view about what should happen over the long run with the health system. But in my judgment, and I could be wrong about this, but my judgment is that the American health system is a vast, entrenched system with significant roles for both the public and the private sectors. And I think it's very unlikely, given how big and complex and entrenched this system is, that it's going to move hard one direction or another. That is, it's not going to move entirely toward a publicly run system, or one with very little role for private initiative or private sector institutions. Nor do I think it's going to go entirely in a market sort of direction without a lot of public role in terms of subsidization and regulation. In other words, I think we're stuck with this big, complex, messy public-private system. Therefore, I'm interested in ideas that try to take this as a given and use that as a starting point for figuring out how to make it better, work better, operate better, serve the public better. I don't want to speak for the congressman, but I see his plan that we'll hear about in a few minutes as fitting in with this general overall perspective. It's try to be a little more practical about where do we go from here given the realities that exist on the ground. So I think he deserves a lot of credit for coming forward with an idea that breaks free a little bit from the decade-long debate we've had over the ACA and its merits. After we hear from the congressman, Joe Antos, my AEI colleague, will moderate a panel that I'll participate in, where we will dive a little more deeply into what's going on the campaign trail, what plans are being put forward, what are the implications of them, and what are the politics around them. So we'll hear about that toward the end of our program. But first we'll hear from the congressman. And let me introduce Avik, who will take a few minutes to introduce the congressman. Avik Roy is the president and founder of the Foundation for Research on Equal Opportunity, a think tank devoted to promoting economic policies that are beneficial to all Americans, most especially for those who currently have the least resources. He received a medical degree from Yale and spent several years examining companies in the biopharma space for Bain Capital on Wall Street, so he knows that industry very well. He's a very active participant in ongoing health care debates on a number of dimensions, including pricing for prescription drugs, and he concurrently serves as editor of Forbes' opinion online pieces. So without further ado, thank you, Avik, for coming. Thank you.
Thanks, Jim, and thanks to all of you for being here. It's my pleasure to introduce Congressman Bruce Westerman to you this morning. I first got to know the congressman when he was majority leader of the Arkansas State House of Representatives. I was traveling the country briefing state legislatures on the ACA's Medicaid expansion and on the decisions that they had to make with regards to that topic. And when Tom Cotton went on to the Senate from the House of Representatives, now Congressman Westerman ran for Tom Cotton's old seat and now represents that district. He's now a third-term congressman. I can tell you he was a defensive back for the Arkansas Razorbacks, so if you like college football, you can ask him your questions about defensive strategy on that side of things. And his son is a graduate of Yale College. I got to know his son because his son was a member of the conservative party of the Yale Political Union, which I chaired, I won't tell you how many years ago. As I got to know the congressman, one thing that has struck me, and I think you'll hear this today, is that there are a lot of people, a lot of members of Congress who really care about getting in front of the cameras, about getting the press release, getting that attention, being able to show that they stand for X and having that associated with their name. This congressman is very much a workhorse, not a show horse. He's a guy who really has been putting his head down, trying to work hard and take on very tough problems in ways that can actually pass the test of getting 60 votes in the Senate and getting bipartisan support. And I think those of us in the think tank world who've gotten to work with him on this project of trying to develop health reforms that can work for all Americans have really enjoyed that process. So without further ado, let me invite Congressman Westerman to the stage to give us some opening remarks.
Thank you, Avik. Thank you, Avik. Thank you, Jim and Joe and everyone for being here today. This is quite an honor to me to get to come to AEI and make remarks. I got to know Arthur Brooks quite well. He used to come over to the Capitol once a month. Kevin McCarthy would have him over and have a small group of us meet with him in his office. And he was going through the material he had researched to do his new book, Love Your Enemies. And I got to kind of, I guess I was the guinea pig or the lab rat, getting to hear how his research was working there and getting to visit with him about some of the in-depth things that he worked on to put his new book together. And earlier this summer, I got a call from a constituent of mine, an older gentleman, and he just said, you have to read this new book. It's called Love Your Enemies by Arthur Brooks. Have you ever heard of it? And I looked over and my copy of the book was on my desk, and as busy as we are serving in Congress, it's hard to find time to read anything for pleasure. But to have a guy back home call me and say, you have to read this. He actually said it should be mandatory reading for everybody that serves in Congress. So I started reading the book, and I could hardly put it down. And I think what Arthur captured in that book speaks a lot to why we're having so much of big issues with health care in D.C. today. He talks about the contemptuous attitude that's permeating through Washington, D.C. and the federal government, and how as long as we keep that contemptuous attitude, it's not going to be good for policy, it's not going to be good for the country. And I think there's probably no issue that we've seen more contempt than in the issue of health care. So it was very fitting that Arthur wrote that book, and that my constituent encouraged me to read it at the time that he did as we were working on this bill. My staff always tells me you've got to tell people your social media account, so if you want to find out anything more about me or the bill, you can go to @Rep Westerman on Facebook and Instagram and Twitter and all that good stuff. To lead off today, I want to tell you a little bit about why I'm interested in healthcare. Avik mentioned that he worked with me some when I was the majority leader in the Arkansas legislatures. We waded through the Affordable Care Act, and I learned firsthand what federal policy does to states. We all think of the ACA as federal policy, but it was a huge job just implementing that policy on the state level. Everything from the exchanges to the Medicaid expansion and the huge domino effect that it had all across the country when a major law like that gets implemented. So I worked through that, I got here to Congress, but we all, I think, have a healthcare story that's affected us in life. Avik mentioned my son Eli in his remarks. When Eli was 1 month old, he had a cold, we thought. We took him to the doctor. They immediately put him in the hospital. He had RSV, a viral infection, which most kids get it, but the younger you are, the worse it is. And he just wasn't getting any better. They had him in the little plastic bubble giving him breathing treatments. And the doctor came to us and said, there's this new antiviral drug. It's $5,000 a dose. He needs five doses of it, but your insurance doesn't cover it. What do you want us to do? Well, she could have said it's $50,000 a dose or $100,000 per dose. If we think it's what's going to make our child well, we'll worry about how to pay for it later. So he got the antiviral drug. He got better, and he graduated from college a year or so ago. And it's a great testament to the innovation and the quality of healthcare that we have here in America, where that drug was available. We paid for it, we moved on with life, and that's the way it goes. But people face choices like that they have to make every day. And I can tell you, when you're in a situation like that, you're not thinking about supply and demand or price, you think about price, but there's not really another option that you have. Also, from my business experience, I was a partner in an engineering firm for over 2 decades before I came to Congress, a small business, and every year we got bids on our insurance policy. And every single year that those bids went up, and they went up much higher than the rate of inflation. And if we happened to have someone in our group policy that had a severe illness, the policy would go up a whole lot more the next year. And small businesses are facing that all across the country still today. And not only would the policy go up, the premiums would increase, the benefits would go down, the deductible would go up. And it's a situation that Americans find themselves in every day. It doesn't matter if you're healthy, sick, young, or old. Health care affects every single American, and it will affect you at some point in your life. Health care consistently polls for most Americans as a top area of concern. It accounts for nearly 1/5 of the U.S. economy and 1/4 of federal spending. It's driving our deficit problems with no end in sight. But these costs aren't market-driven. They stem from decades of government involvement in the market through regulations and rules, and were exacerbated in 2010 by the enactment of the Affordable Care Act. For example, in just the last 10 years, insurance deductibles have tripled for people with employer-sponsored insurance. Coupled with high monthly premiums, Americans are spending more and more of their paychecks on health care when that money could be better spent, saved, or put into retirement accounts. In fact, the average American spends roughly 14.5% of their take-home pay on health care. This is simply not sustainable. Instead of setting aside and waiting for the next health care bill to be proposed, or worse yet, have a public option or a single-payer system to take hold, I began compiling a list of reforms that I think both the left and the right can support. And my legislation that we're going to talk about today, the Fair Care Act, or H.R. 1332, it has 2 primary goals: increase the number of people that are covered and lower the per capita cost for those who are being covered. I address public and private payers, drug prices, provider competition, as well as healthcare innovation. We can do this. When you start looking at the magnitude of healthcare and the complexity of it, it seems like an overwhelming problem. But I can tell you that as you get into the individual issues and start looking at what's the best thing to do, what are the best ideas out there, it's something that we can do that's attainable, but it's going to require bipartisan support. And, I recognize this, having gone through implementing the ACA from a state level, seeing the contentions in Congress around health care, and quite frankly, neither party's been able to do it on their own. The Democrats gave us the Affordable Care Act. They did it on party line votes. They had 60 members in the Senate. They were able to get past the filibuster when they first passed the ACA. And then we tried to do the AHCA a couple of years ago, and it failed by one vote in the Senate. Nobody has the market cornered on good ideas on health care. So our objective was to find the best ideas for health care and implement those ideas. We didn't screen them to see if they're Republican ideas or Democratic ideas, but what are logical, reasonable ideas that will make health care better in this country. And that's what you have in the Fair Care Act, is a compilation of those ideas. We would create a guaranteed protective pool program that helps pay for the highest risk individuals. It allows insurers to charge less for private insurance coverage. I remember as I was in the state legislature learning more about health care, I met with a former executive of Walmart who talked about how they addressed the health care issues within their obviously very large company. And they said that the numbers were something like 10% of the people account for 85 to 90% of the cost. And they said health insurance for so long had focused on the 80 to 90% of the healthy people, where all the costs were in the 10% people. And they really started focusing on how to deliver better health care for those 10% who were creating most of the cost of health care. And what they found were there were a lot of people who would get misdiagnoses on very serious diseases, so they would always go get a second opinion, and they might take an employee on a corporate airplane to the Mayo Clinic or some other center of excellence so they could get a second opinion from experts in the field. And they found by focusing on how to deal with the high cost in the areas where most of the costs were, they were able to lower their health care costs. Well, this is really kind of the idea of a guaranteed risk pool. You take the sickest individuals and you cover their cost through a risk pool, and you're still spending government money, but you're doing it in a more effective and sensible way than some of the programs that we have now. We continue to cover patients with pre-existing conditions, and we allow consumers to shop for coverage across state lines. We reinstate the 5-to-1 ratio on the age band. I think what we've got in the bill goes a long way towards creating solvency for Medicaid and Medicare. I've served on the budget committee, and Medicaid it's the endless pit of money, and that's how the states see it. I've heard more times than not, it's free money from D.C., and there's no limit on how much you can spend on Medicaid. However much the state spends, the federal government matches that. And that's why you get these crazy things like provider taxes, where a state taxes itself because the percentage of the tax they pay, they get a matching rate from the federal government to help pay that tax. It makes absolutely no sense to do that. So Medicaid's not really in danger of defaulting, but it just continues to grow at terrific amounts of cost each year because there's no limits on how much you can spend on Medicaid. Medicare, on the other hand, the CBO tells us it's on a path to insolvency. They keep adjusting the dates, like 2030, and Social Security's right there with it. We're not talking about Social Security here, but many of these programs that are driving the debt and the deficit are unsustainable. So we need to do something to make these programs sustainable over the long run, and we address that. Number one, by moving Medicaid back to what it was intended for, the aged, the blind, and the disabled. And there's a better way to provide care to low-income individuals. I think we can do that through the individual marketplace, but we have to get a robust individual marketplace so that there's more competition on it. We give states more opportunities to design healthcare programs that meet the unique needs of their population. We would clear red tape that limits the entrance of generic and biosimilar drugs into the market and make experimental new drugs more accessible for patients with severe illness. I've already co-sponsored a bill with Democratic rep from Illinois on reducing the exclusivity period for biosimilar products. There's the CREATES Act was something that Senator Leahy had in the Senate. So we're bringing in Republican and Democratic ideas, and we've got those encapsulated in the bill. We break up hospital monopolies and insurance monopolies. That's one of the big problems, I think, with driving up cost is monopolistic systems, whether it's in hospital providers, mainly in urban areas. We do try to help hospitals in rural areas because in districts like where I live, you may be 30 or 40 miles to one hospital, and that's your only option. You take that away and you're 50 to 100 miles away from a hospital. So you can't just paint with a broad brush with a country as big and diverse as ours, because it really causes disruptions and doesn't lead to good outcomes. We encourage the use of innovative technologies like telemedicine to help provide high quality care to even the most rural Americans. After introducing the Fair Care Act last February, and we couldn't have probably picked better timing because we introduced it a couple of weeks before President Trump came out and said we were going to start working on health care again, and Republicans were going to be the party of health care. I think the national media looked across the board and said, well, Republicans don't even have a plan, and they said, who's this guy Westerman that's not on Energy and Commerce or Ways and Means? He's some engineer and forestry guy, and he's got this big health care bill out. So I got to talk a lot about the Fair Care Act. I've visited with a lot of my colleagues. There's a lot of interest on Capitol Hill about the Fair Care Act. And from that, we've gained more ideas and more things to put into it. We're going to introduce a new version. We actually had hoped to roll out Fair Care Act 2.0 around this particular meeting today, but Legislative Council is not on the same timeline that we're on, so we're still working on it, which is a good thing because we're getting even some additional ideas. We're going to expand on the ability for consumers and beneficiaries to choose what healthcare options work best for them. We're going to allow health savings accounts to be used for direct primary care and individual market insurance. I know a lot of people have talked about that, but the first time I heard about using HSAs for direct primary care was from a provider back home in Arkansas. And I find that just by talking to people in the healthcare field, I get the best information out there by going home and talking to people that know healthcare. I had a great meeting last week with an independent pharmacist who had charts and data and was showing me how that what's happening with PBMs and how that if this keeps up, you're not going to have independent pharmacists, that they're literally going to be put out of business with the way the system's arranged right now. So it's always good to go back and talk to people. I've had meetings with physicians groups. I met with the head of Arkansas Blue Cross and Blue Shield, and they like the idea of what we've got. And what you're going to see is, we'll never agree on everything, but I think this is a great starting point to come together on ideas. And I think America realizes that we can do a better job, and people are willing to give some things up to get stability and to get a good plan going forward. And we'll never come up with a health care bill that everybody agrees 100% on. But I do think we've got a great framework here that we can build on, that it can gain bipartisan support. I've had Democratic members come in my office and go through the bill, and they'll be like Republican members that come in my office and go through the bill. I really like this. I'm not sure about this part, but those are the kind of conversations that we need to have, and it needs to be an open and honest dialogue on what is best for Americans, what's best for the consumer, what's going to give us the best health care and move us down the road in the right direction, so that someday health care is not the topic that's dominating discussions on federal policy. We can move on to other things. And if we get health care right, we can do more to address the debt and the deficit than probably anything else that we do. It's that important of an issue. And that's why, even though I'm not on the authorizing committees and I don't have a background in health care, It's extremely important, and that's why I've put so much time into it, why I've had my staff put so much time into it, why we've worked with people like Avik that can get really, really deep in the weeds, and why we want to work with everybody in the room to come up with the absolute best ideas to make healthcare in America the leading healthcare system in the world and make it far above all the rest, and not go down the road of copying what the rest of the world's done and think that's what's going to be better for the United States. So again, it's a pleasure to be here. I look forward to having a chat with Avik, and I don't know if we're going to do question and answers, but it'll be good however we do it. So thank you for your time, and great to be here.
Well, first of all, let me say thank you for being here, and thanks for all the hard work on this plan. For those of you who haven't gone through the text of the legislation or even the section-by-section summary, we at my institution have put out a brief summary of the plan, which is, if you're in the room, it's on your tables, and for those of you watching online, we will be posting that summary of the bill online at our website, FREOPP.org. That's FREOPP.org. I want to spend some time on the policy, and then maybe we'll talk about the politics of health reform and your bill. Starting with the policy, I mean, it's a pretty impressive bill. I mean, what you've tried to do is you're trying to expand coverage and reduce federal spending at the same time, something that a lot of people either have given up on or think is impossible. What led you to decide that that was the course you wanted to take?
Well, I mentioned earlier that we've tried to do this down partisan lines, and it's not worked. So if you think about the two issues that seem to kill healthcare policy is one, if CBO scores something and says it's going to cover fewer people, it's kind of the death knell for it. That was one of the big problems with the AHCA. Whether CBO is right or not, if that's the way the score comes out, it makes it tough to get policy moved forward. We know the rising cost of healthcare. If CBO puts a score out that says healthcare policy is going to increase the cost of healthcare, that's pretty much a non-starter for a lot of people on Capitol Hill. So why can't we have better healthcare that covers more people, that covers pre-existing conditions, and lowers the cost? And I'm convinced, 100% convinced we can do that, because when you get into the details and you start looking at different systems and the way they're put in place, the way they're being taken advantage of, if we can make healthcare fair, we can also make healthcare lower cost and make it available to more people.
There are 5 titles to the bill. The first title is about private insurance reform and the tax policies related to health reform. The second is Medicare and Medicaid reforms. The third and fourth are hospitals and drugs. I always get them mixed up, which is Title III and which is Title IV. And Title V is digital health reform, trying to reform the way how patients own their medical data and how that can be deployed to improve their care.
Yeah, all kinds of innovation in healthcare.
One thing I'm struck by, there are 2 things I'm struck by in terms of the overall policy thrust of the Fair Care Act. The first is as you mentioned up on the podium, your big belief is that the right way to reform healthcare is for more Americans to shop for their own health insurance as opposed to getting it from the government or their employers. And the second thrust is, as again you noted up there, employers are generally failing to control the cost of healthcare. I know at FREOPP, our premiums went up 15% last year. And we are pretty smart about the way we pick healthcare benefits, just like you were at your engineering firm. 43% of Republican voters support or are open to a public option, a government-run insurance plan to compete with private insurers for their employer-based health insurance. So it seems that even among Republican voters, there's an increasing skepticism about the role of private insurers in the private market in delivering health insurance. And a big thrust of your plan seems to be to try to tackle those problems so that employer-based insurance and individual insurance work better. Tell us about why you came to that approach.
Yeah, well, number one, I think it's because I'm a free enterprise person, and I believe that the free markets are always a better approach than having a government-run system. I mean, think about Medicaid. Some plans are being called Medicare for all. I'd say they'd be much more aptly named Medicaid for all. Find anybody that thinks Medicaid's the best healthcare program out there. Providers don't like it. Studies have shown that the benefits to the beneficiaries are not, or the outcomes aren't as good for other health coverage programs. And then you've got the VA, which is another probably model of what a single-payer, big government-run program would be like. I know when I was doing engineering work, I was doing projects in the UK, and I remember visiting with folks there when they were talking about their national healthcare system, and they explained to me that being a visitor to the UK, if I had an emergency, I would go to the emergency room, I would be seen, probably get good care, and it wouldn't cost me anything that they would pick up the tab for it. But they said if I was a resident of the UK and I thought I might have cancer or some serious disease, that it could literally be 6 to 8 months before I could get in to see anyone. I remember this gentleman telling me about his wife, who was an emergency room doctor, that gave up medicine because of the red tape involved in providing services. And then they talked about how they passed this national health care system to give everyone equal access and better care. And they said it did more to stratify health care in the UK than anything you could have ever imagined. That the ultra wealthy built their own kind of country club hospitals and clinics. They went out and hired the disenfranchised doctors and medical workers to work in their clinics, and they had their own private health care system, while everybody else that couldn't afford that suffered on the government-run program. So I really think that, and especially in America, that the free market is the best way to go. You've got to get competition there, and competition not only helps with prices, but it also helps with innovation. And we want to keep American healthcare in the forefront as a leader in the world, and free markets are the way to do that.
One of the people on our team who's here in the audience, Kara Jones, has a lot of experience working with employers who offer health benefits, and she has pointed out to me that a lot of employers, and not just voters, there are voters who are skeptical of employer-based insurance and how their deductibles have tripled and how their premiums keep going up and their wages are staying stagnant. But employers are also starting to feel like they're throwing up their hands and saying, we can't control healthcare costs. We want to get out of this business. I mean, what are you hearing from employers? And you talked about Walmart, but how about the smaller businesses, the 50 to 100 employee companies? What are they saying about healthcare?
So, I haven't been a part of a small business since 2014 when I got elected, but I know that for a decade or more, it was a major concern with our company every year. How much can we spend on healthcare? How much of the burden are we going to have to shift to the employees? And every year we were having to spend more as a company, plus shift more of the burden to the employees, plus reduce the amount of benefits that the employees were getting. So it's a frustration. It's really not something you have a lot of power to deal with. You kind of take what's offered to you. You get bids on your health insurance providers, and you take the best one out there, and you go on and hope for something better the next year. If we can create a larger individual market and get more competition on the individual market, if we can do more to address the real issue with increasing healthcare costs, and that's increasing prices, then I think we can not only help people who are getting insurance on the individual market, but also help those who are getting insurance through their group plans.
Let's talk about the politics now. So obviously, health reform is always hard. It's always hard to get conservatives and progressive Democrats and Republicans to agree. It's hard to get voters to agree. It's hard to get lobbyists to agree. There are all sorts of people who have a stake in the system one way or another. How have you found it navigating all that? And when you started on this endeavor 2 years ago now, and you said you wanted to put together a bipartisan health reform bill, has it been harder than you thought, or about as difficult as you expected, or easier than you thought?
I would say easier than I've thought to go out and gather the information and compile it and to analyze the data and figure out what should be in the bill and what shouldn't be in the bill. And it's also created a basis where I can go talk to Democrats, I can talk to Republicans, and make valid arguments on individual policies. So I think that's how our country was set up and how it should be. But I mean, unless you've got a 60-vote block in the Senate, you're just not going to get healthcare policy on the floor of the Senate unless you do it through budget reconciliation. And what I found out being on the budget committee and wading through the AHCA is you're limited on what you can do from a policy standpoint when you're trying to do it through budget reconciliation. You know, the fix to the ACA had to be done through reconciliation. It was pushed through in December. Senator lost, Democratic senator lost, Republican senator won, so they didn't have the 60-vote threshold, and they had to come back and try to fix it through reconciliation, and I don't think it's ever been fixed. But I think we can take the good ideas, get bipartisan support, and if we want the best for healthcare in our country, that's the approach that we have to take.
Do you find when you talk to voters back in your district that people are excited about the opportunity to have more choices in their health insurance, or is their attitude more, just get the cost out, I don't care if I have choice or not? Or is it both?
I think people want the choices. They want value for what they're paying for. And that's why we call it the Fair Care Act. You pay for a service and you're going to get the fair services back that you've paid for. We want consumers to feel like they're getting a good value for what they're paying for. Right now, people are just paying enormous amounts of their disposable income for health care. I know, personally, I'm now a participant on in the individual marketplace as a member of Congress. And, instead of a group plan like I had previously, I have to analyze individual plans for my whole family. And when my kids went to college, we found it was always less expensive to buy whatever plan the university had for students and not participate on the exchange with the whole family. But it doesn't have to be that way. If the exchanges are a good idea, they just have to have more people participating on them and more options on the exchanges.
Maybe we can go back to the policy since you brought that up and talk about some of the key elements of the plan. So one element, Title I, a lot of Title I is about repairing the individual market so it works both for people with pre-existing conditions and healthy people whose premiums have raised up. You mentioned on the podium the idea of reinsurance or a high-risk pool to directly cover the costs of sicker people so that premiums go down for healthy people and more people can enroll, widening the age bands and some of these other reforms to make the individual market stronger. One thing that plays into that is the reforms on the employer-based side. So you mentioned about how in Congress you now shop for coverage on the Affordable Care Act's exchanges. One provision in the Fair Care Act is to transfer all federal employees onto the exchanges, where they would use health reimbursement accounts funded by the government to shop for individual market coverage. You also have a related provision in the bill that would take advantage of a new rule that's come out from the Trump administration to not only enable existing employers to optionally fund health reimbursement accounts or health reimbursement arrangements so people can buy coverage on their own, but starting in 2021, every new startup, every newly incorporated business, that would be the model going forward. So new businesses that were founded after 2021 would also would be required to fund, if they wanted to take advantage of the tax break for health insurance, fund health reimbursement accounts so the workers could control those dollars and shop for coverage. So a lot of really interesting and subtle but significant policy tweaks that over time will lead the individual market to be a lot larger than it is today. And one could see it actually tripling or quadrupling or even more in terms of the cumulative effect of all those reforms. Tell me about that thinking. I mean, you're really making a bet that that the individual market can be a lot better than it is today, and that it can serve a lot more people than it does today.
Well, we see from private insurance that the larger the group, generally the more value you get in your plans. And that's why you see large employers self-insured. They have enough employees, then they have a large enough group. They have good bargaining power, good buying power, and they're able to negotiate better. And you can almost think of the individual marketplace as a massive group plan. And the more people you can get into that plan, and the more insurance providers you get offering plans on the exchange, then you're going to have more competition and more options. And I think it's just a great approach to lowering the cost for individual consumers. And that's the main thinking behind increasing the size of that pool. You mentioned the Federal Employee Health Benefit Plan. That's, I believe, around 10 million people, give or take, that would automatically make that plan larger. If you look at the people who are now covered under the Affordable Care Act who weren't covered before, most of that took place under the Medicaid expansion. We would also like to get away from fee-for-service Medicaid and the Medicaid expansion and take that population and use a premium assistance program to help them get onto the exchanges as well. And then finally, the option for new businesses that start up after 2020, 2021, they would be able to participate in the individual marketplace as well. So the idea is to grow the individual marketplace and make it what that marketplace was originally intended to do.
I'm going to ask one more question, and maybe we'll open it up to a question from the audience. Since we're here at AEI, we should mention that one of the ideas you're considering, as you mentioned at the podium, for the new version of the Fair Care Act is to incorporate a version of competitive bidding into Medicare and Medicare Advantage. We talk about the individual market a lot. We forget that Medicare Advantage is the largest and most robust individual market in the United States. Tens of millions of Americans are enrolled in Medicare Advantage and shop for coverage every year through robust competition for private plans. And you're thinking about expanding the role of competition in the Medicare program to bring those costs down for seniors and for taxpayers. Maybe mention that a little bit.
Yeah, and I
should
mentioned
mention Jim Capretta is the guy who is the really originator of a lot of this work.
Yeah, and I think that's a great idea on how you get competition there, so that the federal government seems to want to get assurances on capping cost, and that's kind of how they've set up that program on Medicare Advantage, where you get to share in savings. Well, we want the taxpayer to share in those savings and not just have a set cap. It kind of goes back to the conversation I had with the independent pharmacist on the DIR fees. Like there's an average amount that the federal government expects to pay for a prescription. Part of that goes to the pharmaceutical company or the pharmacist. Part of it goes to the PBM, and the government gets to save money, but all the cost savings being squeezed out of the individual pharmacist. We want to be able to competitively bid and let the markets work so that we can get the cost even lower for Medicare Advantage plans.
Right. All right, questions for the congressman? Yes, ma'am. There's a mic coming. And please introduce yourself.
Thank you. Hi, I'm Sarah Hansard with Bloomberg Law. Congressman Westerman, can you comment on the role of Medicare prices? I've been doing a good bit of reporting on how employers pay so much, 2-3 times more than Medicare price, and then doctors and hospitals keep saying, well, the Medicare price is too low, that's why we have to charge employers more. Do you have any thoughts on that? I mean, somebody sets, and I've talked to Avik Roy about this, somebody sets those Medicare prices. Do you think that they're really set too low, or should we use Medicare as a benchmark for what employers should be paying?
Well, that's the world we're in right now, and I learned this through just a lot of research and talking to people back when I was in the state legislature, that Medicare prices set the price for everything. Insurance reimbursements are pegged off of Medicare reimbursement rates. Medicaid reimbursement rates are pegged off of Medicare reimbursement rates. And when you get into the details of that, especially talk to surgeons and other physicians, and they talk about how the system is so messed up. Like I remember a neurosurgeon was telling me about a certain back surgery where there were 5 or 6 things that needed to be done to make the surgery successful, but Medicare only paid for 2 or 3 of those things, and he can't do a halfway back surgery, but he can only get paid for half of a back surgery. We've got to get healthcare providers, and I'm talking about doctors, more involved in setting those, not necessarily setting the prices, but outlining how those payments should be. Whether we stick with Medicare continuing to control that, we don't necessarily address that in the bill, but I agree with you that it's probably not the best way to do it. So if anybody's got a better idea on how we attack that from a pricing standpoint, I'd be open to hear it. But it just gives everybody a reference point to work from, and they're always working from how much Medicare will reimburse for certain procedures. And maybe that's an area we need to look at in the bill that could have a good impact. Do you have ideas on that? It sounds like you've researched it.
Tell providers will pay you what Medicare pays. And I go round and round because you talk to different people, including Mr. Roy, I believe, different people have different ideas about whether Medicare really is underpaying, or, have providers, or at least hospitals, shifted costs to, into their system that then becomes a higher cost basis, or...
And what I've found is it depends. You'll find some things where they really underpay and some things where they overpay. And you've seen a move towards these clinics that don't accept Medicare, they don't accept Medicaid, they don't accept insurance, and they're able to price medical services based on what the cost for those medical services are. I know an individual who shifted his company to a plan that basically took advantage of these concierge services. He tore a rotator cuff, and he called around. He was in Little Rock, called around, and I think the price was somewhere between $25,000 and $30,000 to have the surgery in Little Rock. But there's a surgical center in Oklahoma City that they would pay for his transportation out there and the surgery, and the price was more in the $5,000 to $6,000 range. So they were charging what the true cost was to perform the procedure, not what Medicare said was the rate, and what the hospitals tag on to make sure that when they're through negotiating, they're going to make a profit off of the service. So somehow, if we can get back to more transparency in pricing, where the consumer is actually paying for the cost of what goes into the procedure, I think we would be better off.
Well, Congressman, I just want to thank you for being here and for the impressive work on this proposal, this bill, which I think any healthcare expert who studies it is going to be very impressed by how serious it is at addressing a lot of the problems that we all agree we need to tackle. So thank you very much.
Thank you, Avik.
And I know the Congressman will be around. For the rest of it, I'll give the mic back to Jim. Okay.
By the way,